quick. Good morning, everyone.
Good morning.
Good morning. Let's turn on the cameras.
Hello, Professor. I'm getting word that Shahina and Abby are going to be 5 minutes late.
Okay, thank you. Excuse me. Oh, I don't see Amir and Munir either. Then Mary, Alan, Olga, Sebara. So there are quite a few absent. Vishal, Christy,
I just checked
Nabila.
in.
Okay. Dolly, you have a question?
Yeah, hi, Professor. My apartment has a possible gas leak, so I might just be in and out for a little bit, but I'm dealing with that right now.
Okay. No problem.
Professor, can you check me in? My
I'm
phone's
sorry, who
dead.
was it?
That's
Amir?
why.
Okay. Sure,
Appreciate
I'll
it.
check you in, Amir. No problem. Okay, you are checked in, sir. Cherry, you have a question?
Yeah, did you get my message on the chat? I just have to go to my boyfriend's reenlistment ceremony for the Army at 12, so I'm just going to switch
Okay.
to my phone.
Okay. No problem. Thank you.
Thank you.
Professor, could you check me in? I'm on my phone right now, and also wanted to let you know that I have an appointment with my surgeon at 10:30, so I'm gonna be on my phone for majority of the time.
Okay. Okay, we have quite a bit of students absent. Can someone drop a text for these students? For Olga, last time
They're all
Ibarra?
signing in right now. They're all
They
texting
are.
saying, we're coming in, we're coming in.
Okay, okay. Let's just give a couple of minutes then. Anybody, any of you have any question, anything else while we're waiting?
Professor, it's Bella. I'm gonna be switching to my phone like around 11:30 so I can go take my son to a doctor's appointment later today. But I'll be on my phone.
All right.
Good morning, Professor. Can you please check me
Morning.
in?
Okay, sure.
Thank you.
You're very welcome. All right, you are in. So students, I'm missing Olga, last name Abara, Vishal, Christy, Shahina, S. Ortiz, Trina, Taylor. These are the students I'm still missing.
Hey, who are your brothers?
How are the studies going? Everybody creating study guide, practicing questions? Okay, thanks, Christian. How about others? How things are going?
It's good.
It's good? Okay, good. Glad to hear that. Olga, how things are going?
Good.
Yeah, okay, perfect. Miss Ortiz, how about you? You're on mute.
I think I'm doing okay.
All right.
Thank you for asking.
You're welcome. Okay, thanks, Nabila, for letting me know. Amika, how about you? Everything going well?
Yes.
Okay, perfect. Harjot, how things are going?
Don't even ask, Professor. I don't know.
Why?
I don't know. Yesterday's PowerPoint just didn't go in my brain.
Like, have a clear plan in your mind, okay? Have a clear plan, what you're gonna do and follow by giving enough time to each activity. When we say, I don't know, it's mostly that we're trying to still organize things and we're falling behind, right? But it's important that you plan. We cannot just go blindly that, okay, I'm gonna sit and just gonna keep doing things until I'm done. Well, we need to decide that what are the activities I'm going to do and when and for how long. Set up timelines. Okay. Alan, how about you, sir?
Okay. I looked through the slides again
Oh,
after the meeting and then just trying to
great.
revise.
Okay, good. Stephanie,
Yes.
how things are going? How the studies?
It's good. I looked at the slides for a bit, but I worked last night, so I didn't get too much of a chance.
Okay. How about you, Munir?
Pretty good. Just kind of stressing about the Complio stuff for right now.
Okay. It's okay. It's everything gets sorted out. Don't stress out. Miss
Yep.
Brown, all right? Okay. All right, Andre, how about you? Sitting there quietly. How things are going, sir?
Pardon?
How things are going at your end?
Oh, okay. So I'm just trying to figure out like what I should filter out into the study guide from my notes. Transferring some of my notes to the study guide and comparing how it aligns with the notes in your study guide. I also am trying to make my own flashcards to recall things because I found that recalling is my biggest issue, like knowing the drug names. So I'm trying to reassure that by just flashcards, recalling drug lists, especially in mnemonics and
That's okay. We got it.
yeah. So it's just
Okay.
kind of
Okay. I will give you a little suggestion. It's a great idea to use flashcards, but I personally wouldn't spend too much time on creating them. Your time is more valuable. I would spend $20 to get what is available rather than spending 6, 8 hours to create them. And whatever I save, I will spend that to learn. Again, everybody learns in different ways, but we have to assess the situation we are in because we cannot do things in the similar manner, not necessarily all the time. So here, because time is something always short. So, I personally feel like, to look into things, how can we save time and still utilize those resources?
okay. I'll take note of that. Thank you, Professor.
Yeah. Ramanpreet, how about you?
I'm doing great, Professor. Just learning new things, new methods, how to go with it.
Okay, perfect. Okay, Bella,
Yes,
doing all
Professor.
right. Doing all right. How the studies are bothering you, or are you bothering the books?
No, I'm studying. I'm trying to figure out how to write down and space together the medications and trying to catch up with the stuff I missed from yesterday.
Okay,
But doing
great.
okay. Thank you.
Okay, perfect. Yeah. Remember, excuse me, have clarity once and then follow the plan. That, okay, this is what the resource I'm going to use and how I'm going to use what I'm studying from there, right? We cannot, for example, if you have 4 resources, we cannot use each resource for each purpose. We have to narrow down that how or what part I'm going to use from this resource and what from another one, and then make your own unique, like the study guide when you're making, and as been saying, 70 to 75%, at least your exam, I try to cover during the lecture. So your PowerPoints are real good basic study material, can give you a solid platform to kind of do well on top of that. So making sure that we cover the PowerPoints well is crucial. So that part, please make sure that you are first covering up your PowerPoints. Okay. Right, I still see Sabara, Vishal, Christy, Shahina still absent. So any word from any of?
Hina's on her way. She's doing it.
Okay, so let's move on, and then whenever they show up, we'll see. Okay, where did they go? Okay, guys, let's move on. Yeah. Okay, can you see the full screen? Yes. Okay.
Yes.
Perfecto. All right. So today, once again, we'll be covering two chapters. They are also very important chapters, and I'll point out what are the most important things you should remember or know. Okay, so antivirals. Now we are moving into a different zone. Okay, these are not antibiotics. These are the drugs who manage viral conditions. Okay, viral. So we'll talk about different type of conditions which are caused by viruses, including HIV and AIDS. In brief, we're not gonna dig too deep in that. And then medications commonly used, any contraindication, adverse effects, some of them we'll be looking into closely. And then what are the important aspects for you as an RN to look into while you're developing a nursing care plan or your whole nursing process thing while your patient is on any of these medications. First of all, any viral condition, if your patient is starting an antiviral, the basic thumb rule is the sooner they start, better it is. The reason behind that is that virus keep replicating, right? Keep replicating. The sooner you interrupt that replication, making its own copies, right? The defected ones, you put a stop on that the sooner, the earliest you can, you are not letting them making their own copies and becoming more stronger by increasing their number. You're not letting their army become stronger. And if we say like, oh, the patient comes and say, oh, it's already 4 or 5 days, but I'm still suffering, I want to take an antiviral. Unless it's real severe, I don't see much utilization of an antiviral at that point. It should be started, the best scenario I would see within 2 days to see the best results. Now, let's talk some basics. Viruses, they're really tiny, small microscopic, your infectious agents, which can replicate inside the living cell, not outside. They need a host to replicate and increase their number. Okay, so they could be in animals, plants, bacteria, fungi, any place they can grow on. Now, they are much harder to kill. And also, there is always a risk of damaging the healthy cells, okay? Because it's hard to target just the bad guys. Along with them, these drugs can hurt the normal healthy cells as well. So there are a lot of adverse, unwanted effects comes along with that. So we have to keep that in mind. The reason they stop the replicating, okay, the growth phase, and the normal cells, they are in that same process as well. So they both get impacted. What we are trying to stop and which we had no intention to. So virus, their life cycle goes through different steps. And let me show you something here. I would suggest something here, similar way what I suggested yesterday about your antibiotic, that how we draw cell structure, right? And then point the arrows wherever the drugs are acting, write down their mechanism on top, and then example of each one under that class. So similarly here, I want you to make something like that or utilize this and then point arrows wherever those drugs act, write down the mechanism of action, and whichever the drug acts at that step of the viral cycle, write down some common names and then create a mnemonic for that as well. Okay? For example, if you see here, attachment. Okay, guys, there are many cameras off. Is there a reason? Some of you did ask for that, but if you did not, I don't want to see any cameras off. Okay, Alan, Stephanie, Harjot, Ortiz, Kristen, Christian, Amanda, Mahek, Katie.
My camera's on.
See all these
They're
people.
on. Is it a glitch
My
thing?
camera's been on.
That's weird.
We could see all these people, Professor.
Really? Do. Now I can see you. Yeah, I'm not sure why. On my end, the many cameras showing up. Not few, a lot. I don't know why. Well, anyways, so here, attachment. Okay, attachment, that's a nucleus. Okay, and this is example, influenza virus. So it has to go in. It has to go in to manipulate the genetic material of a healthy cell, right? So it needs to attach. It goes on the surface and just say, "Hey, how are you doing? Can we sit and talk?" So it's just trying to gain entry inside the cell so they can manipulate the genetic material inside. So binds to specific receptors on the surface. There are specific receptors of the host cell. And then penetration. So penetration where it gains the entry into the host cell. And then uncoating. What happens during that inside the host cell, now the virus protein, the outside coat, it starts to open up, releasing the DNA, RNA into the host cell. Okay? Then, excuse me. After that, there's replication, transcription. Now, it gets mixed up into the normal DNA, RNA, and then make defected copies. And those defected copies goes out. They now go and similarly say hello here to other healthy cells and then make defected copies there as well. So at one point, there are a whole lot defected copies as compared to the healthy one. And that is called viral load, the number of those defected copies there. The higher they are, the sick the person is. So the goal here is to keep the viral load low. And the number, magic number, is below 200. Okay, that's important to know. So like in your HIV/AIDS patients, you need to keep that below 200. If it's above 200, means it's not well managed. The virus are replicating. Okay. Any question, guys? Any questions so far? Okay. Now there are so many different viral viruses and so many diseases, conditions because of them. But not all viruses present makes people sick. Some doesn't do anything, but these are some common viral infections. Uh, like influenza is one of the most common one can go through every year, caused by influenza virus. It could be different strains, A, B, C, causing fever, cough, sore throat, fatigue, body ache, and all that. And usually caused by the airborne droplets, direct contact, and you can prevent it by taking the annual flu vaccines. So your common cold, that's your rhinovirus. It could be coronavirus, adenovirus, kind of similar kind of signs and symptoms like runny nose, sore throat, cough, sneezing as with influenza. Then COVID, we all know. HIV/AIDS, that's caused by the human immunodeficiency virus. And then the transmission is with blood, then sexual contact, and mother to child. Then hepatitis, that's your A, B, C, and then can damaging the liver, causing jaundice. That is common. Then herpes simplex virus 1 and 2, which causes oral and genital sores. Then your chicken pox and shingles. It's caused by the varicella zoster, and there are vaccines for that. Then measles, caused by measles virus, and there's a MMR vaccine for that. Then polio, caused by poliovirus. Dengue. So these are like common viral illnesses, and many of them had preventative vaccination available. So it's always beneficial to educate your patient to stay on top of that and staying current with all the vaccination. Now, let's talk about antiviral drugs. First of all, important to know, educate your patient that it's not only going to kill the bad guy, the virus we are trying to, it is going to hurt your healthy human cells as well. Okay? And that is the reason the patient may experience different type of toxicities because of these drugs. So that is very important to know about that and educate your patient, because they're probably expecting the drug is going to make them feel better. They're saying, oh yeah, this thing I'm feeling, I'm feeling a little better, but hey, I'm experiencing this. Now these drugs, they are chemicals, drugs, which kill or suppress virus. How? By destroying the virions, the causative organism, or inhibiting their ability to replicate further. Remember, the goal is not to let them replicate. That is real important about that. And there are different conditions which can be effectively managed with the utilization of these antiviral drugs. For example, your hepatitis, herpes, HIV, influenza, RSV, they're effective drugs available. These drugs can enter the cells, the viral cells, and then manipulate how they replicate. Now, remember how these viruses, they gain entry and then manipulate the genetic material, healthy cell, and then make defective copies. Similarly, the drugs get in and they manipulate their genetic material, and eventually they don't have their normal copies, which are defective for us, but for them, that's normal, and they start dying. They cannot replicate anymore. And another important thing, the sooner you start, the better it is. And the reason is that immune system has to be strong to recover quickly. Drugs alone may not help that enough. It may shorten the amount, or not the amount, I'm sorry, the duration of sickness, but it's not going to cure the treatment, the disease right away. Okay, these wild drugs, they shorten this duration of the sickness. So if the patient's saying like, oh, 2 days and I'm still kind of having the symptoms, well, it's not gonna wipe out everything right away, because it's trying to put a stop on further replication, and eventually the viral load will go down and your body will recover. But it's not killing those viruses right away that you can feel better that quick. So a competent immune system is important because it just works synergistically with the medication to suppress the viral activity. Okay, now I don't know if you guys know the difference between these two or not, but let me explain. Antiviral and antiretroviral. Now, if you talk about a generic umbrella term, they both, you can say that they're antivirals, right? But there's a slight difference between them. The drugs you use in HIV/AIDS, they're called ART therapy or HART therapy. They means antiretroviral drugs or therapy. Okay, antiretroviral. And the drugs used for all other viral infections other than HIV/AIDS, they are called antiviral. Okay, is that clear? Okay, drugs used for HIV/AIDS, they're called antiretroviral. Remember ART, antiretroviral. And any other condition, viral condition, with drugs that treat those conditions, they are antiviral. Okay? And if somebody asks you, how do they work? Well, they inhibit the viral replication. So they all work the same way. Everybody heard about Tamiflu? Tamiflu? Anybody heard about Tamiflu? Oseltamivir? Yes? No?
Yes.
Yeah. So what it's used for?
It's used for the flu.
Yeah. So that's a very common example. Oseltamivir, Tamiflu, for influenza. And if you're educating your patient about that medication, tell them to start as soon as possible, within 2 days of the symptoms started, because the later they start, less the effect is. Acyclovir is a prescription, another prescription, very important common drug use. Now, antiretroviral, as I said, they target the retrovirus, like your HIV, because they use the reverse transcriptase to convert their RNA into DNA inside the host cell. So these drugs inhibit the viral enzymes, such as I just mentioned, reverse transcriptase or protease or integrase, and that's how they're named. Reverse transcriptase inhibitor, protease inhibitor, integrase inhibitor. That's how these HIV drugs are named. So we're going to talk about that as well. Now, these are common conditions like our HSV1, HSV2, chickenpox, shingle, Epstein-Barr, cytomegalovirus, CMV. Now, it's important to know the difference between HSV and 1 and 2 and also what drug is used. HSV is a herpes simplex virus. Now, number one causes oral lesions, oral herpes, okay? Like a cold sores around the mouth. That is HSV1. HSV2 causes genital herpes. It causes sores and blisters in the genital area. And they're very hard to manage. You cannot treat completely. You can only manage. It comes on and off, on and off. The mode of transmission usually is a direct contact, skin to skin contact, HSV1, kissing and all that, and HSV2 is more sexual contact. Those blisters could be quite painful. And as I said, very manipulative. It's really hard to manage. Then the medications you can give, such as your acyclovir, valcyclovir, famciclovir, those are the commonly used drugs. So we're going to talk about these conditions individually. Once again, HSV1 is oral lesions, HSV2 is the genital. Now, HSV2 in neonatals, it's called neonatal herpes, which can happen, or the virus can be transmitted from mother to the baby. Now, it's important to know, and I have seen this question in NCLEX a lot of times, that if the mother has active genital lesions, active, not just the history. These are two different situations. If the mother has active genital lesions, so they should not deliver vaginally. They should deliver the baby via C-section to prevent that transmission. Okay? That is quite important point I've seen many times. Now, another common concern here, shingles. Shingles, okay? Shingles, it's also caused like herpes zoster. This is caused by the reactivation of virus called varicella zoster. Okay, varicella zoster. It's, once again, let me point out again, it's reactivation of varicella zoster. So means it's not a new infection. So person was somehow exposed to the varicella zoster. Now, who gets exposed? Usually the kids who develops chickenpox. Okay, it's the same virus. So this condition is experienced by patients who were ever exposed, who got exposed with what? Varicella zoster virus in their life, usually when they're a child. So that is an important point to know. It's not that people just get sick, that they just got exposed to that. The virus, the first time, suppose like in childhood, they got exposed to that, they got sick and the blisters were there, painful, and that fever and all that. But then after a few weeks, the blisters disappeared, everything went normal. Now there's a high chance that the virus went dormant, okay, inactive. It's just laying down without bothering the patient at all for years, and not even years, decades. Usually it pops up again when the patient becomes old, 60, 65, around there, when their immune system is down. Now this pops up again. And the patient experience tremendous amount of pain, real discomfort, not managed well with NSAIDs or other pain medication, they may need topical, such as your lidocaine and all those, and opioids to manage their pain. It could be that devastating, real severe. So what can we do that the patients who were exposed to this chicken pox in their childhood, so around, their 55, between that 55 to 60, they should get that vaccine, the shingles vaccine, the Zostavax or Shingrix, to prevent the shingles developing in them. Okay, and the pain usually develops if the reactivation happens in these patients, and the pain develops exactly in the nerves wherever those the blisters were, like decades ago, because this virus kind of lays dormant in those nerves, and then wherever they were, that's where the blister, you won't see the blisters, you may not see the blisters at all, but the pain will be at those spots. Okay, and that is called post-herpetic neuralgia, PHN. That's what it's called. Is the nerve pain in those areas wherever the rash or those blisters were. Okay. Any questions so far, guys?
I have a question. So, for those that don't get the, like I have the vaccine for varicella, but I never got varicella as a child, even before the vaccine. Would people like that be susceptible to getting shingles because they have the vaccine, or would they not ever get it?
Very low chance. Again, anything can happen to anybody based on the circumstances at that point, how the patient's, that person's immune system is at that age. Are there any underlying conditions which can put them at high risk? None of the vaccine can protect anybody 100% for any condition. It reduces the chances. Okay, like for example, your flu vaccine, right? We see every year, like you go to see doctor. Did you get your flu vaccination this year, right? Everybody says it, but the data says it's. I mean, most of the times, okay, not always. Most of the times, the data says 50%. There's a 50% chance that it will help your immune system to protect you from the flu, and there's a 50% chance that you still can get sick. Understand? So there are a lot of factors, and none of these vaccines, none of the drugs can protect anybody 100%. But yes, it there are two things. One is that it reduces the risk of getting it. Second, that it definitely reduces the severity of the disease even if you get it. Does it make sense? So it reduces the severity. For example, in US, we don't have that the BCG vaccines for tuberculosis anymore, right? Because we're able to eradicate and we didn't need it. But the many countries in the world, they still use it because there's still high risk in the communities. So the vaccine can reduce the chances of getting infected. But more importantly is it can reduce the severity of the condition that most likely it will prevent the virus from damaging their lungs if they have that vaccine. But it doesn't mean that they cannot get the condition. Okay? All right.
Thank you.
You're welcome. Now, hepatitis C. Now, this is a real dangerous condition, high risk hepatitis C. it can damage the liver real quick. Okay, causing what? Jaundice. So watch for yellow, yellow, yellow. Means the white part of the eyes yellow, tears yellow, all secretions. Okay, sweat yellow, urine yellow, sputum yellow. All these things can indicate the patient may have liver injury because of hepatitis C. And it could be severe that they may need a liver transplantation. It attacks the liver. And usually it happens due to direct contact, blood to blood contact. The people doing drugs that they share needles, um, medical equipment which are not sterile. Okay. There is some risk associated if mother has it, and during childbirth that can happen as well. Okay. And then Hep A and B, they do have vaccine, and C doesn't. So the best thing is to prevent it and avoid sharing the needles and unprotected protected sexual activities. Ensure that if the blood transfusion is happening, that is safe. As far as the mechanism of action of your antiviral drugs, as I said, the target is, the motive is to stop these viruses from replicating further. Because the more copies they have of themselves, the stronger they are. So we need to make them weaker by not letting them more defected copies. Okay, that is what the goal is. Now, if we talk about these drugs, the different, your acyclovir, valcyclovir, all these drugs. So we need to know like which drug is most commonly used for what, and then we know that mechanism of action pretty much gonna stay the same for all. And then, is there anything in particular we need to know about any drug? So as I mentioned earlier, not only not only the bad guys, which are the target of these antiviral drugs, they also target the healthy cells because they're also rapidly replicating. So it cannot differentiate between the bad guy and the good guy. All it knows is that I need to stop the replication. Now here is one of the most common drug here, guys. Okay, so know this drug, acyclovir. Now Zovirax, which shows here, that's a cold sore cream which you apply on here, and usually it takes about 3 to 5 days and just reduces the severity of the condition. Now, another important thing to remember here. If somebody asks you, what is the drug of choice for initial or reinfections of your which condition? Your HSV1, HSV2, or varicella zoster? Your answer is acyclovir. Got it? Acyclovir is the drug of choice for both conditions. If it's initial, patient is getting it first time, or they got healed and now reinfection. Okay? For all situations, acyclovir is the drug of choice. Everybody clear? It's a very important drug. They ask question all the time on acyclovir. This is one of the most common one you will see in any practice, antivirals. Okay. It comes like the topic. This is a topical cream. It comes oral, like a tablet, capsule. Also for severe life-threatening situations, then like your herpes encephalitis, there's an IV form available as well. So once again, it is not going to treat or cure the condition. It will reduces the severity of the symptoms as well the duration of the sickness. Okay. Now here's another one, ganciclovir. This is similar to that acyclovir. Okay. Now important to know about this is the what condition it's used, which is CMV, the cytomegalovirus, and your CMV retinitis. Now, the most important part here I want you to know here is the bone marrow toxicity it can cause. It can suppress the bone marrow. Now, what's happening in the bone marrow and why it's important? The bone marrow is making the blood cells. Okay, so now once this drug suppress the bone marrow, the production of your white blood cells goes down. Okay, your platelets goes down. Now, what's happening if they go down? What happens when white blood cells are down?
Increased risk of infection.
Increased risk of infection. So we need to know that this drug can cause this issue. So we're gonna monitor their CBC. So we can keep an eye. And here comes your drug, oseltamivir, generic, and brand name, it comes as Tamiflu. Very, very, very common drug. Okay, now, important. If somebody asks you, which medication can be used for both influenza virus type A and B? Your answer is oseltamivir or the brand name Tamiflu. Okay? Now, once again, educate the patient. It's not going to cure or treat you. It is going to decrease the severity of the symptoms as well as the duration of the sickness. And once again, important, it should be started as soon as possible. And the best is within 48 hours or 2 days of the onset of symptoms. Okay. Any questions so far, guys?
Yeah, you said it can be used for both influenza and what else?
No. For two types of influenza.
Okay, yeah.
Influenza A and influenza B. Clear? Anyone else? Any other question? Everybody's okay? All right, let's move on. Now, here's another drug, ribavirin or Virazole. Okay. There's only a couple of things which we need to know about this drug. This is not used very commonly. You will see this in hospitalized pediatric patients, okay, pediatrics, babies, kids getting sick with RSV, respiratory syncytial virus, RSV. It's a respiratory condition. Okay, respiratory condition. So this drug you will see utilized in an aerosol form. If you see in the picture, see that's the mouthpiece for the inhaler, right? So we deliver the drug in inhalation form. The patient inhales it, aerosol form, micro particles. Now these tiny particles, aerosol, can travel in air for many, many hours. They're so tiny and not enough weight that they can settle down on any surface. They just keep moving around in the air. It could be for 8 hours, 10 hours. Now, why is that important? If they're moving around, let them walk, right? What is the problem? The problem is that this drug has a black box warning, pregnancy category X, means there are enough reported cases that can cause teratogenic effects on the fetus. It can hurt the fetus. So the risk is that if a pregnant person, maybe it's the mother or somebody else, family member, or even a provider, if they walks in the room in that time, those 8 to 10 hours, it's still spread out in the air. They can inhale it and it can stay in their body for many, many months, even 4 to 6 months. And it can cause teratogenicity. So important here is to know that pregnant women should not enter the room. Okay, everybody understand that point? Is that a yes or no? Yes, okay. Because there are many of you, I don't know what trick you are doing. On my end, the camera doesn't show anything. I just see your names there. So I don't know if the head is going this or going this. So please speak up, let me know. Okay.
I have a question. Is it just why
Yes.
they are taking the medication, or is it a certain time after as well?
I'm sorry, what was that? Can you say that again?
Should it be just why the patient is receiving the medication, or a certain time after they stop the medication as well?
No. So as I said, the aerosol, the particles can stay in the air from 8 to 10 hours. So that is the window that during that period, no pregnant person should enter. Okay. But once, if they inhale it, then it will stay in their body for many months. All right. Now, let's talk about HIV and AIDS. Do you guys know the difference between HIV and AIDS? No? Yes? A little bit? More? Yes? No?
Don't you have to have you first get HIV, and then if you get an infection, it can like progresses to AIDS or something like that? Like they're one leads to the other, right?
Yes. So HIV is the human immunodeficiency virus, right? So that virus goes in, can cause AIDS, but everybody having that HIV doesn't mean that they have AIDS. Does that make sense? So this virus attacks the immune system of the patient, specifically the CD4 plus the T cells, and weakens the body's ability to fight infection. So for these patients, even minor conditions could be real severe for them. Like if they get somebody got UTI, somebody got diarrhea, even that is difficult to treat because their body is not going to fight. And AIDS is acquired immunodeficiency syndrome. So this is the actual condition caused by HIV, the virus. HIV is the virus. AIDS is the result of that, the virus. So this
So
is the final and most severe. Yeah, go ahead.
I was gonna say, is AIDS like a form of an HIV?
Okay.
Or is it a whole different
AIDS
thing?
AIDS is caused by HIV. Yes.
Got
HIV
that. Yeah.
is the virus which causes AIDS.
AIDS. Okay.
Makes sense? Okay. Because HIV, somebody may get exposed, it may lie dormant for 10, 15 years. The patient may not have AIDS at that time. It may never happen. It may happen when their immune system goes down. Okay. So this is the final, most severe stage of the HIV infection. There's a significant drop in the CD4 cells. Harjot, your question?
Yes. What prevents HIV to going to AIDS? Is there like a prevention, or it just happens by itself?
There's nothing in particular, but the best thing to do is hygiene, avoiding any situations which can weaken your immune system. Keeping your immune system healthy is something real important in these kind of patients. Well, another thing is if somebody somehow, like in healthcare field, like somebody got a needle stick, right? So there's a risk that you may have gotten exposed to that. Then usually they call PrEP. It's a prophylactic treatment, even though there's no confirmation that you got exposed to it, but that exposure might put you at risk of getting infection at some point. Then these antiviral drugs, in combination, they are given in order to try prevent that infection from happening in future. Okay.
Thank you.
Mm-hmm. So here the CD4 cells, they go down, and that puts your patient at risk of all kind of opportunistic infections. These people can get sick real quick. Okay. Now this virus can stay dormant for a long time. But in healthcare, the most common thing here is the needle stick injuries. And then if that happens, it should be reported right away to the supervisor, and they should refer to the healthcare provider, and the healthcare provider should start the prophylactic therapy. And you don't need any confirmation for anything. It should be started right away. Okay. I'm going to show you a short video so that you can have clarity about how this HIV cycle works.
When HIV first enters the human bloodstream, the virus circulates throughout the body. The protective surface of HIV is studded with particular proteins called GP120, and inside is a capsid that contains the viral RNA and viral enzymes. Initially, the GP120 protein on the virus is only able to bind to a cell surface protein on the macrophage called the CD4 receptor. A second receptor protein, CCR5, must also be present on the macrophage for the virus to enter the cell by endocytosis. Viral RNA and enzymes are released into the cell's cytoplasm. Reverse transcriptase uses the viral RNA to synthesize first a strand of viral DNA and then the complementary DNA strand. The viral DNA then moves to the nucleus of the cell where it integrates into the host cell's DNA. Transcription of the DNA within the nucleus now results in the production of viral RNA. This viral RNA can serve as the genome for new viruses and can be used as messenger RNA to produce viral proteins during translation by the ribosomes. Complete viruses are assembled and released from the cell via exocytosis, which causes little harm to the macrophage. HIV cycles through macrophages over a period of years and continues to multiply while doing little apparent damage to the body. Eventually, the gene that codes for the GP120 protein is altered by mutation. The altered GP120 protein changes its co-receptor allegiance and now binds to a different co-receptor, CXCR4, which is found on the surface of CD4 plus T cells. The same processes occur within the T cells, resulting in new virus particles. However, as these new viruses leave the T cell, they rupture the plasma membrane, which kills the cell. As these newly released viruses invade and destroy other T cells, the body's immune response is weakened, and this leads directly to the onset of AIDS.
Okay, so hopefully kind of give you a little bit of idea that how this thing works. It's really a tricky one. It's really a tricky one. Is there anybody who did not get a chance to scan the QR code who came late?
Yeah, I didn't scan it, Professor.
Katie? Is that
Shahina?
you? Oh, Shahina. Okay. Let me see. Did you have a hard time joining, or you had your own concern? It was technical issues. What was going on?
Yeah, I was running late.
Okay. Do anyone else? But Vishal, Christy. So Ibarra, none of them here? Nobody heard from them?
Professor, Joseph said that he wouldn't be able to make it. He said he had an emergency and he messaged you on Canvas.
Oh yeah, he did. Okay, yeah, I forgot about yes. Did. But I didn't hear from Vishal and then Christy. So none of you, no word from them in your group, anywhere? Okay. Let's watch another quick video. This will show you, once again, this is just an example. You don't have to do exactly the same way, but this is similar to the video we saw yesterday, that how to develop that master slide, putting things together. So how I was saying in the morning, I want you to organize. So draw a structure, and wherever these drugs act, just point an arrow, write down the mechanism of action on the top, and write the drugs under that category. And then, you develop a mnemonic for that. So I just wanted you to kind of share it for a few minutes. Let's watch this.
You got a ricotta with Calvani,
I'm
Italy's
not offering
#1
this, guys,
cheese
okay?
brand.
Think of a poem about your identity. Funding our school is a big challenge.
HIV. Antiretrovirals work on different parts of the viral life cycle. All patients with a HIV infection should begin antiretroviral therapy as soon as they are ready, regardless of CD4 T cell count. So let's recap the HIV life cycle to understand the pharmacotherapy, the drugs used to treat HIV. HIV targets the CD4 T cells, such as this cell here. The CD4 T cell are the human immune cells. The glycoproteins on the envelope of the HIV, GP120, binds to CD4 receptors, together with the co-receptors CCR5 and CXCR4 on the surface of T cells. This allows fusion of the viral envelope with the cell membrane, which is facilitated by the glycoprotein GP41. Fusion releases the capsid with the viral content, including the enzymes necessary for viral survival. The third step, reverse transcription, involves the virus reading its own genetic RNA material and then making a DNA copy of it with its enzyme reverse transcriptase. From a single-stranded viral RNA, the virus produces double-stranded viral DNA, which will be transported to the nucleus of the host cell via integrase. This allows integration of the viral DNA with the host DNA, which is the fourth step in the HIV life cycle. The HIV virus is now part of the cell, essentially the CD4 T cell, and can use the cell's own machinery to create more of its genetic material and more of its structures in order to make more HIV viruses. Transcription is where the host's own RNA polymerase reads the viral DNA, and with that information, it creates viral RNA, which is the genetic material, as well as mRNA, which will be used to create important proteins for the virus. Translation is where the mRNA that was just made is read by the host's ribosomes to create proteins that will essentially create the enzymes and other proteins required to make a new HIV virus. All these enzymes, proteins, and the viral RNA that is created gets assembled, packaged up, and released by the CD4 T cell. Once released, there is a final process of maturation where the HIV virus uses its enzyme again to form its final infective form. While the virus replicates within the CD4 T cell, it actually injures the cell itself and thus causes a slow reduction in the CD4 T cell count. Antiretrovirals are the cornerstone to treat patients with HIV. These antiretrovirals work on different parts of the viral life cycle we just learned. All patients should be started on antiretroviral therapy. Let's learn about these antiretrovirals by looking at each step of the HIV life cycle. Now, there are several antiretrovirals which block different stages of the process of attachment and entry. The CD4 binding inhibitors, such as ibalizumab, the monoclonal antibody, it binds to CD4 T cells, inhibiting the HIV virus from entering the cell. You also have CCR5 inhibitors, Maraviroc, which mechanism of action is, as the name suggests, it blocks the CCR5 co-receptor that is essential to cell infection for some HIV genotypes. Common adverse effects of this drug include hepatotoxicity and rash. There are also antiretrovirals which inhibit fusion, such as enfuvirtide, which mechanism of action is it competitively binds to the viral protein GP41 and thereby prevents fusion of the virus envelope with the cell. This is an injection, and so common adverse effects include localized skin reaction. Then you have the antiretrovirals that target reverse transcription. Most of these drugs end in INE, ein, except two very important reverse transcriptase inhibitors, abacavir and tenofovir, which you have to know. Now, the two main types of reverse transcriptase inhibitors are the nucleoside reverse transcriptase inhibitors and the nucleotide reverse transcriptase inhibitors. And both work to essentially stop the enzyme reverse transcriptase and so stop the creation of DNA, the viral DNA. Nucleoside reverse transcriptase inhibitors include abacavir, lamivudine, and zidovudine. Essentially, these drugs work as a thymine analog. They incorporate into the viral DNA via reverse transcriptase, essentially disrupting the creation of the viral DNA, and thus terminates the DNA chain. Here you have the single viral RNA. The reverse transcriptase helps create the viral DNA. Nucleoside reverse transcriptase inhibitors, such as abacavir, act as a thymine analog, disrupting this whole process, terminating the strand early. Abacavir specifically is important to know because it is commonly used. Side effects of abacavir include hypersensitivity reaction, and so patients with abacavir normally undergo genetic testing to exclude HLA-B 5701. Abacavir also increases the risk of cardiovascular disease, and so patients with pre-existing heart conditions, you must be careful. Now, the nucleotide reverse transcriptase inhibitors, the most important to know is tenofovir. Now, the mechanism of action is that it is a adenosine nucleotide analog and acts again as a chain terminator when incorporated into the viral DNA. Tenofovir comes in two forms: tenofovir disoproxyl fumarate, TDF, and tenofovir alafenamide, TAF. TDF and TAF are oral tablets. They differ in half-life and effects on the kidneys and the bones. Both TDF and TAF are taken up from the gut when you swallow the tablet and act inside the cells to inhibit reverse transcriptase as mentioned. However, TDF has a shorter half-life and is taken up by the kidneys more readily. TDF is more present in plasma, and because of this, it's taken up by the kidneys and increases the risk of nephrotoxicity as well as bone toxicity, leading to osteoporosis. Those are the two main types of reverse transcriptase inhibitors.
I'm just stopping this one because I wanted to show
The
you how
nucleotide
to
and
develop it. We don't need to play the whole thing, but just wanted to give you an idea on how to prepare the slide and putting things together on one piece that you can understand that what is the mechanism of action and what are the drugs who acts with that mechanism of action. So kind of giving a little visual tool there can help you remember that slightly better than just the words on a piece of paper. So any questions so far? No? Okay. So antiretroviral drugs. So as we say, antiretroviral for your HIV/AIDS, not for other viral infections. It's also called as ART, means antiretroviral, or HART, which means highly active antiretroviral, means they have multiple drugs with different mechanisms. Okay, one may be reverse transcriptase inhibitor, other was integrase inhibitor. What they're doing is It's like you're trying to stop a bad guy. Okay, who's strong? You know that there's a chance it may manipulate and kind of play around. So you are putting up multiple checkpoints to make it weak at every checkpoint and eventually stopping it to move further. Okay, that is the reason that there are usually at least 3 different drugs when you're treating your HIV/AIDS patients. You wanted to target the different steps of the life cycle of the virus. You're making them weak at every point. If you just give them one type, it's not going to happen. You need really high dose to make it weak, but now that's going to damage your organs. So you go with multiple drug approach to keep their doses low, but you're making them weak at multiple checkpoints. Does that make sense? So all these patients, you will see multiple drugs. Okay? And it should be started immediately as soon as the confirmation. If you're doing for that, it should be started right away. But in case of accidental injuries, they don't wait. They just give it. Now, the main motive is the goal is to keep the viral load low, means the number of virus. And what was the number again? Anybody remember?
200?
Below 200.
200. Yeah, below 200. Good job. Okay, now here are some common classes under HIV/AIDS therapy or antiretroviral or highly active antiretroviral drugs. These are reverse transcriptase inhibitor. If you remember in the video, remember at different places it was showing reverse transcriptase, protease, right? So all these different drugs, they act on those different checkpoints and they inhibit. That's why they're reverse transcriptase inhibitor. They inhibit the reverse transcript enzyme. Protease inhibitors inhibit the protease enzyme. Fusion inhibitors, they prevent replication, they prevent the fusion getting together. So you need to know that which one acts where. Okay. Now, for example, here, your fusion inhibitors. So as the name says, they inhibit fusion. So they suppress the fusion process where the bad guy, the virion you call, that microorganism, is attached to the outer membrane of the host T cell because they need to attach with the T cell to gain entry. Okay, so that's where you try to prevent that fusion so that they cannot gain entry. This is only available, your amphibiotide or fusion, only available in IV form. Okay, now this is a very common class, protease inhibitors, very commonly used. As the name say, they inhibit the HIV protease enzyme, which is necessary for maturation of the viral particles. Once this drug inhibits the protease, such as your indinavir here we're talking about, it prevents the virus from producing the new copies. And that leads to reduced number of virus, which means low viral load. Okay, they usually take like every 8 hours or so. Now, if you see here, they end in vir. So pretty much all of them, you see they end in vir. So those are your protease inhibitors. Okay, best taken empty stomach for better absorption and consistent absorption. There's different type of food consumed, and the breakfast can alter the amount of drug absorbed based on whatever the diet is. Okay. Now here's another one. This is the CCR5 antagonist. CCR5. So as the name says, CCR5. So it blocks the CCR5 co-receptor, which is right next to the CD4 cells on the outer membrane. So HIV uses this receptor to enter the cell. So once you block it, such as this example, Maraviroc or Cellzentry, this is a common drug used for this purpose. So the virus cannot gain the entry. If it cannot gain the entry, it cannot open up, manipulate the genetic material inside, and making defective copy. So you're blocking it right there. Another example here for a different class, which is your NNRTIs. They're NRTIs and NNRTIs. They're called transcriptase inhibitors, so either nucleoside or non-nucleoside reverse transcriptase inhibitors. They work by binding to HIV enzyme, which is your reverse transcriptase. Now that is essential for them to replicate. Once you block them, they cannot replicate again. And that's what the purpose is. And we don't want them to replicate further. Okay. And if you see all of the drugs saying they're used in combination, because the reason is you cannot effectively manage this condition by using only one type of medication. They are always in combination, usually minimum of 3. Then here's another common one, your raltegravir or Acentris, that falls under integrase inhibitors. As the name says, they inhibit integrase, the enzyme integrase. They're called INSTIs, integrase strand transfer inhibitor. Okay, now how does this connect? What does this to integrase do, which we are trying to block? Okay, how does it work? Well, this integrase enzyme is responsible for integration of the viral DNA into the host cell's genetic material. So once you block it, you're preventing the HIV from replicating within the host cell. And if they cannot, now they cannot bind with the host cell's genetic material and make copies of defective genetic material. Okay, now this drug can cause myopathy and rhabdomyolysis. So watch patient for muscle pain, dark color of urine that may indicate rhabdomyolysis, the muscle protein breakdown, and that is coming into the urine now, causing the urine to become dark. In that case, if not managed at earlier stage, it can damage patient's kidneys. Okay. Okay. Next is your tenofovir aviriate. This is also your reverse transcriptase inhibitor, but this is a nucleoside, not non-nucleoside. It's nucleoside reverse transcriptase inhibitor. So it will inhibit the reverse transcriptase. Once again, that enzyme is required by the virus to replicate. Once you block it, they cannot replicate. Okay. Lactic acidosis, and then watch for your liver issues. Liver issues is something important. Now this is important, okay? This is more important. Zidovudine or retrovir. What is important about it? This is the first NRTI in their class. Now, a couple of things which are important. Number one, this drug is approved to use in pregnant as well as in newborns. Okay, so that's important to know. This is the drug of choice in pregnancy as well as in newborns. Number two, it causes bone marrow suppression. Now remember, we talked earlier as well. Bone marrow suppression causes what? Blood cells going down, your WBCs, platelets going down. So we need to monitor that CBC. And if patient experiencing any signs and symptoms of sickness, such as, they're saying fever, sore throat, fatigue, all that could indicate the patient might be going through that toxicity and causing bone marrow suppression, which is leading to reduced blood cells. Okay, any questions so far?
Are these all the same drugs that you would get for a like an employee needle stick? Like they give you the cocktail or whatever they call it?
Yeah, there some get like 3 different, but some of them comes in combination as well, like 2 drugs in one or 3 drugs in one. And yeah, any of these could be utilized for prophylaxis as well.
Thank you.
You're welcome. Excuse me. So as a nurse, what is important for you when you're taking care of your patient who's on this medication? First of all, having enough data to evaluate your patient is the most critical part. Get a detailed history, any conditions, signs and symptoms, what they eat, what they drink, taking any medication, herbal, supplement, anything. Get that information. Then set a baseline, their vitals. Nutritional status. Nutritional status is also critical in these patients because they kind of always deficient. So you have to keep a close eye on that and making sure that they are healthy. They're not deficient nutritionally. Then baseline vital signs will give you a standard to compare with before the treatment, what the baseline was, and with your treatment, how the patient feeling now, and you compare, like, is it the same? Is it worse or better? Give you that information to kind of evaluate that is the treatment is on the right track or we need to make any adjustments. Okay. Also teach them there are various types of products available, formulations. So educate them based on what the formulation is. Inhalation could be different, topical is different, oral is different. One basic, very important point is hygiene. The reason their immunity is weak, right? Their immunity is weak. WBCs are down. And anybody whose immunity is weak is always high risk for infection. Tell them, stay away from very sick people because your immunity is not strong enough to protect you. And making sure hand hygiene, they follow that because once again, they're at a high risk of infection. And one of the most common one is, this is if you don't do this, you're touching surface, you're eating, you're drinking, that all those infectious agents gain entry and they can make them sick real quick. Also, if there is any body secretions, especially in the blood, don't ever touch that without wearing a glove, and do not dispose it in the regular disposal container. It should go in biohazard. Okay, and there is all facilities have procedure guidelines that how to clean the surface. They have those different chemicals to utilize to completely disinfect the surfaces. And also, excuse me, tell them not to eat cold foods or leave anything outside the fridge and then, eat it after an hour or so. No. Same, even the water, they should not leave it outside and then keep drinking it all day here and there. That's not safe for them. Okay. They should cook things, not raw. Also, very crucial, it's a very basic point, as I always say, but it's one of the most important things. Compliance in these patients is critical. They cannot skip a dose. They cannot skip it. Even missing one dose in the whole month can put them at the same risk. Very high risk. So they have to be compliant, highly compliant. Make sure they understand that, because none of this medication is going to cure their condition. It's management. And what we are managing, keeping the viral load low by giving these drugs. We're not killing the virus. We can't. We are suppressing them, not letting them replicate. Virus is still there, but once they skip the dose, the load will go up. So we need to make sure they understand. And no matter how long you've been taking from, you're not cured. Okay? Monitor for therapeutic effects and as well as any adverse effect, as we're talking about one of them, like the bone marrow toxicity. So we should be aware about that, the medication we're giving, what to expect, and what are the signs and symptoms of those adverse effects if the patient is taking those medications. Okay, any question? We'll take a break, but just if anybody have a question. No question? Okay, so it's 10:35. Let's come back at 10:45, okay?
Professor, are you still there?
Yes, I am.
I just really wanted to ask for a quick favor. Do you think we can do a 15-minute break just so I can grab something to eat? Please?
Okay, but everybody left and, they're probably not hearing now. So
I
if
can
I
text
say
it.
that they're gonna, okay, that's fine.
Thank you so much.
Mhm. Okay, welcome back, everyone. Excuse me. Let's come back. Come on, everyone. Please turn your cameras on. Okay. Okay, let's see. Let's do some questions. See if you remember. Okay, good job. So much all of you answered A, acyclovir. If you remember correctly, genital herpes, it's caused by HSV2. And we talked about it, initial as well as recurrent episodes of HSV1, HSV2. The drug of choice is acyclovir, right? Okay. Okay, how about this? Okay, nice. Perfect. Yeah. So D is the correct choice. Remember, it causes bone marrow suppression. Causes bone marrow suppression. So you need to monitor the blood cells by performing CBC. Everybody understood like why we're doing CBC? Okay. Next. Good job. Yes, correct. D, antiretroviral. HIV, AIDS drugs are antiretrovirals. All other condition, all other viral, the drugs we use for them, they are antiviral. Good job. Okay. Okay, great. Yes. Once again, D is the correct choice. Viral load. HIV, it's a a viral condition, and we need to check the viral load because we have a goal to keep it below what number?
200.
Oh,
200.
200. Yes, perfect. Good job. Okay. Okay, perfect. Yes. All of you answered correctly. B is the correct choice. Oseltamivir, the brand name Tamiflu. Okay. One thing I want to remind you here, do not mix this influenza virus A and B with HSV1 and 2. Okay. For HSV1 and 2, it's the acyclovir. And for influenza A and B, it's oseltamivir, Tamiflu. I mean, that one is 1 and 2, and this is A and B. Okay. Okay, perfect. Once again, good job, good job, good job. B is the correct one. Herpes zoster. Okay. Yeah, that's it for this chapter. Now, let's approach chapter number 2, last chapter for today's lecture. And this is also important. There's some unique things we're gonna go over, and it'll be important to remember those. Okay, so we're going to talk about the condition, which is tuberculosis, caused by what? What are the signs and symptoms? Then the medications for treatment, any contraindication, interactions, adverse effects. Some of them, as I say, we're going to see some unique things. And then important parts of your nursing care plan or nursing process while your patient is taking these medication. Now, as far as tuberculosis, first of all, is a highly infectious disease caused by Mycobacterium tuberculosis. They also call them MTB, means Mycobacterium tuberculosis. Now, which organ is primarily affected in this condition?
The lungs?
The lungs. Good job. Now, does anybody know why lungs?
Is it because it's airborne?
Okay, anything else? Any other angle? Okay, your this virus, not okay. I mean not virus. Okay, this bacteria, it's aerobic in nature, means it needs oxygen to survive. And which organ has most supply of oxygen? Lungs. That's why I decide to settle down there. Make sense? Because commonly we think, oh, because we inhale it, that's why it's no. It's because that's what it needs to survive. It's aerobic, needs oxygen. Now, what is the transmission? Well, respiratory droplets. When who's infected, they cough, sneeze, talk at that time, can transmit. Right? So it's airborne. Spread through respiratory droplets. Now, symptoms. Patient have persistent cough for a few weeks. They're coughing up a lot of sputum and blood. They're experiencing fever, night sweats, they are tired, they're losing weight. Those are signs and symptoms of pulmonary tuberculosis in the lungs. Well, can it affect other organs? Yes. Is it common? No. It can travel and affect other organs in the body, but majority of the time you will see it's more restricted in the lungs itself. Okay. Now, how do we know? How do we diagnose tuberculosis? Number one, the skin test, PPD, right? Protein derivative test. Or it could be IGRA, it's called IGRA, interferon gamma release assay for the latent TB. Somebody who got exposed to it, but they don't have an active disease yet. Then somebody with active tuberculosis, it's a chest x-ray. Then sputum culture, when you collect patients' sputum first thing in the morning for 3 consecutive days. Okay, or the molecular tests are available. So this is important to know. Okay, the treatment usually it's called RIPE therapy, and I'm going to go over why it's called RIPE therapy. And then their first line, second line. But this is how it looks like lungs, they form like granules, so the body, the immune system makes like a capsule, a granule to surround the bacteria so that it cannot infect. Now it can stay there for a long time. At some point it can rupture and bacteria can cause an active disease. But in the X-ray, you could see these granulomas. Okay. This is, as I said, it's an aerobic, a rod-shaped microorganism which requires lots and lots of oxygen to grow, flourish, and that's why affecting the lungs. Now, it could be transmitted from different sources, such as humans, cattle, birds, but very low. We are here focusing on human transmission. Okay. Okay. So once again, airborne, transmitted by droplets. When patient cough, sneeze, speak at that time, and the healthy person can inhale, and it can stay in the lungs or it can spread further. I'm going to show you real quick, a short video, just kind of a better clarity about that, how they infect people.
Tuberculosis, also known as TB, is spread through the air from one person to another. When someone with pulmonary TB disease coughs, TB bacteria are expelled into the air in tiny water droplets. These droplets can remain floating in the air for several hours, making it possible for someone nearby to inhale them. Once a person has breathed in droplets that contain TB bacteria, they travel down the trachea and enter the lungs, where they collect in the alveolar sacs. Once in the alveolar sacs, the bacteria begin to multiply. The body's immune system starts working and macrophages begin to surround the bacteria. A granuloma is formed to keep the bacteria from spreading. The TB bacteria remain in the lungs, but the body is protected from disease by the granuloma. In 8 to 10 weeks, the person will most likely test positive for latent TB infection. The progression from latent TB infection to TB disease occurs when the granuloma break open and the TB bacteria multiply. Then the person becomes sick with TB disease and may be infectious. This progression can occur immediately after infection, many years later, or not at all. When the TB escapes from the granuloma and begins destroying a person's lungs, it's called pulmonary TB. TB bacteria can also enter the bloodstream and travel to other parts of the body, causing extrapulmonary TB.
Okay, so hopefully kind of give you a little information to kind of visualize that how this thing works. But it's highly infectious. Another aspect is that it does not grow rapidly. It's a slow growing organism. And the slow growing organism are hard to treat. Okay, they're hard to treat because when you give them drugs, they block their replication, stop them from further replicating. The more rapid they are, it's easy to target them and stop. But when they're slow growing, that's a little bit more tricky, and that's the reason that it's hard to treat this condition and takes longer to contain. Okay, so it's a little hard one. So patient has to take the medication for many, many months. The primary TB is when the first time they get infected, and a patient may get treated and it may develop it again at some point, and that is called a reinfection, which is chronic tuberculosis. Now, dormancy highlighted there, it means that patient got exposed to it, and when they go for example, they went for like the PPD skin test, they inject really small uh, uh, liquid in there just under the skin, intradermally, and after 72 hours, they take a look on that, the duration, like how big that is. And then if it does come as positive, it doesn't mean necessarily that the patient has active TB. It could be because they got exposed to it. So that's a period of dormancy when they got exposed. They have it, the organism is in the body, but it's not causing the disease yet. So that's a dormant period. Here's a example I was talking about, the how to diagnose it, right? So diagnose as your tuberculin skin test for latent TB who got exposed but do not have an active tuberculosis disease yet. Okay, so it's called Montux or PPD tuberculin skin test. They go in there, usually this area, they inject just a small fraction of the sample and then observe it and then assess it after 72 hours. They call it as the induration, the area, kind of not only the redness, you'll see that the bump thing in there if they're positive. So you have to measure it, how big that is. Okay. And then if that comes positive, you should send your patient for a chest x-ray. And if that shows signs of tuberculosis, those granulomas, we see the round granule things, then they should go for culture of sputum, which should be collected for 3 consecutive mornings, the first thing without brushing, first thing in the morning. And if they come positive, means they have active. If that comes negative, means they don't have an active disease. That's something usually they do even after treatment for 3 consecutive mornings. They assess the results. Then there is a interferon GABA release assay, IGRA they call. Okay, they see that I measure the immune response to the TB antigens. And this is usually done for people who have BCG vaccine done, because if somebody has a BCG vaccine in their childhood and they're going for this tuberculin skin test, they're going to come positive for that because they had the antibodies. Okay, so chest X-ray is usual method. Anybody had a BCG vaccine, they usually send them for chest X-ray. Anybody has it, you should tell them like, hey, I had this BCG vaccine, so the tuberculin skin test is going to come positive, so they'll send you for chest X-ray to check active disease. Then we got the sputum culture and all that. Also, they could do the bronchoscopy, more severe things, or CT scans, but these are the usual things done. Now, years ago, there was lot of concern about multi-drug resistant tuberculosis when people who travel from other parts of the world where TB is still a concern, a big concern. So they were somehow exposed to that. And not necessarily they were sick, but maybe they transmitted others and they got sick and they got exposed to it and came positive for tuberculosis. And the problem was the microorganism is not responding to the usual treatment, which is such as your isoniazid and rifampin was not responding to that. And that was categorized as multi-drug resistant tuberculosis, which are extremely hard to treat, very hard to treat. I may have another video. Let me see if I have it. Okay, let's watch that.
Learning medicine is hard work. Osmosis makes it easy. It takes your lectures and notes to create more. Try it free today. It's estimated that about 2 billion people worldwide are infected with Mycobacterium tuberculosis, often just shortened to tuberculosis or simply TB. 2 billion is a ton of people. But even though they're infected, that doesn't mean that all these people have symptoms. The vast majority, about 90 to 95%, aren't even aware that they're infected. And this is because usually the immune system can contain it, such that it's not able to multiply. It often remains latent or dormant as opposed to active, which usually causes symptoms and can be spread to others. If the host immune system becomes debilitated at some point down the road, like with AIDS or some other illness, or as a person grows older, it can be allowed to reactivate or basically wake up and become very serious, especially if it spreads throughout the body.
Let's learn about C3 glomerulopathy, a rare disease that affects how well your kidneys work.
Mycobacteria are an interesting bunch. They're slender, rod-shaped, and need oxygen to survive. In other words, they're strict aerobes. They've got an unusually waxy cell wall, which is mainly a result of production of mycolic acid. Because of this waxy cell wall, they're acid-fast, meaning that they can hold on to a dye in spite of being exposed to alcohol, leaving it bright red colored when a Ziehl-Neelsen stain is used. The wall also makes them incredibly hardy, and allows them to resist weak disinfectants and survive on dry surfaces for months at a time. Now, Mycobacterium tuberculosis is usually transmitted via inhalation, which is how they gain entry into the lungs. Now, we breathe in all sorts of virus and bacteria all the time, but we've got defenses that take care of most of them. For one, air that we breathe in is turbulent in the upper airways, and drives most bacteria against mucus, which is then cleared pretty quickly. Ultimately, though, TB can avoid the mucus traps and make its way to the deep airways and alveoli, where we have macrophages that eat up foreign cells, digest, and destroy them. With TB, they recognize foreign proteins on their cell surface and phagocytize them, or essentially package them into a space called a phagosome. With most cases, the macrophage then fuses the phagosome with a lysosome, which has hydrolytic enzymes that can pretty much break down any biochemical molecule. TB is tricky though, and once inside the macrophage, they produce a protein that inhibits this fusion, which allows the mycobacterium to survive. It doesn't just survive though, it proliferates and creates a localized infection. At this point, somebody has developed primary tuberculosis, which means that they have signs of infection soon after being exposed to TB. Even though it sounds bad, most people at this stage are actually asymptomatic, or maybe have a mild flu-like illness. About 3 weeks after initial infection, cell-mediated immunity kicks in, and immune cells surround the site of TB infection, creating a granuloma, essentially an attempt to wall off the bacteria and prevent it from spreading. The tissue inside the middle dies as a result, a process referred to as caseous necrosis, which means cheese-like necrosis, since the dead tissue is soft, white, and looks kind of like cheese. This area is known as a gone focus. TB also gets to hilar lymph nodes, either carried over by immune cells through the lymph or by direct extension of the gone focus infection, and causes caseation there as well. And together, this caseating tissue and associated lymph node make up the characteristic gone complex. Gone complexes are usually subpleural and occur in the lower lobes of the lungs. The tissue that's encapsulated by the granuloma undergoes fibrosis and often calcification, producing scar tissue that can be seen on X-ray. This calcified gone complex is called a Ranke complex. In some cases, although a scar is left over, the mycobacteria is killed off by the immune system, and that's the end of that. In other cases, even though they're walled off, they remain viable, and are therefore still alive, but they're just dormant. If and when a person's immune system becomes compromised, like with AIDS or with aging, the gone focus can become reactivated, and the infection can spread to either one or both upper lobes of the lungs. It's thought that this is because oxygenation is greatest in these areas, and TB, being anaerobe, prefers areas of greater oxygenation. Since they were previously exposed, the immune system's memory T cells quickly release cytokines to try and control the new outbreak, which forms more areas of caseous necrosis. This time, though, it tends to cavitate, or form cavities, which can allow the bacteria to disseminate or spread through airways and lymphatic channels to other parts of the lungs, which can cause bronchopneumonia. But it can also spread via the vascular system and infect almost every other tissue in the body, called systemic miliary TB. When TB spreads to other tissues, it causes complications related to the organ affected. Kidneys are commonly affected, resulting in sterile pyuria or high levels of white blood cells in the urine. It might also spread to the meninges of the brain, causing meningitis, the lumbar vertebrae, causing Pott disease, the adrenal glands causing Addison's disease, the liver causing hepatitis, and the cervical lymph nodes causing lymphadenitis in the neck, also known as scrofula. Testing for TB often starts with a purified protein derivative, or PPD intradermal skin test, sometimes known as a tuberculin skin test, MAN2 test, or simply TB test. With this test, tuberculin is injected between layers of the dermis. Tuberculin is a component of the bacteria, and if a person has previously been exposed to TB, the immune system reacts to the tuberculin and produces a small, localized reaction within 48 to 72 hours. If the reaction creates a large enough area of induration, rather than just redness, it's considered to be a positive test. Positive tuberculin tests simply mean that the patient's been exposed at some point to TB. It does not differentiate between active and latent disease. As an alternative to tuberculin skin tests, there are also interferon gamma release assays, or IGRAs, which look for evidence in the blood of previous exposure to TB proteins. Since this one's a blood test, you do not need to show up again to have the test read like you do with a PPD. Also, the IGRA is more specific to TB rather than other types of mycobacterial infections, and is unlikely to be positive as a result of having BCG vaccine in the past, a vaccine that protects against TB. And this is a pretty useful feature of IGRAs, since BCG vaccine is given to many children around the world to prevent disseminated TB. After doing a screen test with PPD or IGRA, anyone with a positive result typically gets a chest X-ray to look for signs of active TB disease. In patients with symptoms like fevers, night sweats, weight loss, and coughing up blood, or hemoptysis, it's important to collect samples from either the sputum or via a bronchoalveolar lavage, which is where the bronchoscope is inserted through the mouth or nose into the lungs. Fluid is squirted, and then the fluid is collected. These samples can get sent to the lab for staining, culture, and PCR to look for evidence of Mycobacterium tuberculosis. Treatment of latent TB infection typically involves using a single drug for a prolonged period of time. The most common approach is isoniazid for 9 months. Treatment of active TB disease is typically done with different combinations of anti-TB antibiotics, like isoniazid, rifampin, ethambutol, and pyrazinamide, which results in patients being non-infectious to others usually within a few weeks. Until that point, though, patients can spread TB to others, and it's typically adults with reactivated TB that are the most infectious. As a result, patients are typically kept in negative pressure rooms, and visitors are asked to wear protective N95 masks that can't filter out oil aerosols, N for not resistant to oil, but can filter out at least 95% of other aerosols, in this case TB. Even after patients are no longer contagious, they're typically kept on multiple medications for many months to be sure the bacteria are destroyed, usually with direct observed therapy, or DOT, where somebody watches and confirms that you're taking the medication. Additionally, there's an enormous worry about new drug-resistant strains of TB that are causing infections in various parts of the world. You might hear of MDR-TB, or multi-drug-resistant TB, or even XDR-TB, which is extremely drug-resistant TB, which is incredibly hard to treat because they don't die in the presence of our usual antibiotics. The bottom line is to get an effective treatment. It's super important to make sure that the drugs being used will work against the specific strain of TB. Multiple medications are used together to prevent drug resistance from developing, and that medications are used for the entire course of therapy so that all of the Mycobacterium tuberculosis is killed off. Recently, the US Food and Drug Administration has approved a breakthrough medication for XDR-TB called pretomanid. According to recent studies, a combination of pretomanid, bedaquiline, and linezolid has been effective for almost 90% of XDR-TB cases. As an added bonus, this combination therapy can be taken orally, and is also very well tolerated compared with other XDR-TB drug regimens. Alright, as a quick recap, tuberculosis, or TB, is an infection caused by Mycobacterium tuberculosis that mainly affects the lungs. 3 weeks after the primary infection, the immune system tries to contain the infection created by a granuloma, and the tissue in the middle undergoes caseous necrosis, resulting in an area called a gone focus. TB also extends to nearby hilar lymph nodes, causing caseous necrosis there as well. The gone focus plus the affected lymph node makes up the characteristic gone complex. If the immune system becomes compromised, like with AIDS or older age, the gone focus can reactivate, and the infection can spread to one or both upper lobes of the lungs, where it forms cavities. From cavities, bacteria can disseminate to other parts of the lungs, causing bronchopneumonia, but it can also spread through the vascular system and infect almost every tissue in the body, which is called systemic miliary TB. Testing for TB starts with a PPD intradermal skin test, or with an IGRA blood test, and a chest x-ray can identify signs of active TB disease. In patients with fevers, night sweats, weight loss, and hemoptysis, a sputum sample can be stained, cultured, and PCR can be done to look for Mycobacterium tuberculosis. Treatment of active TB includes a combination of antibiotics, given for several months, and special regimens are used for MDR-TB and XDR-TB. Thanks for watching. If you're interested in a deeper dive on this topic, take
Okay,
a
I
look at
hope you were
osmosis.org, where we have flashcards,
able
questions.
to understand some basic concepts. Any question on any of them? Everybody doing okay? All right, so let's move on. Let's talk about the drug now. So as I mentioned in the beginning, the drug therapy is usually called as RIPE therapy. RIPE, which is R-I-P-E. R means, see these R's here, 3 R's, rifampicin, rifabutin, and rifampicin. So 3 drugs, either one of them can be used under R's. I means isoniazide, which in short is called as INH. Full name is isoniazide. Next is P. P means pyrazinamide. And E is ethambutol. Okay, streptomycin usually, if somebody cannot take those, and then it can be replaced. But RIPE is what most commonly you will see. Okay, so just remember that R-I-P-E, RIPE. And then, and under R there are 3: rifampicin, rifabutin, rifampicin, And remember this, it's either or. It's not that all three are used in there. So it can be used, one of them can be used. And then isoniazide, pyrazinamide, and ethambutol. Okay. These are your first line drugs. Now, if we talk about second line, and when do we use second line? Second line, when any patient, maybe because of some underlying conditions or any other thing, medication they are taking, which can interact, then you may need to change or switch one of the medication on the primary first line treatment therapy. So that can be used, or the patient is not responding to the first line. Okay, these are also antibiotics. It's your levofloxacin, ofloxacin, all these are antibiotics. There's some injectables available, such as amikacin, streptomycin comes in injectable as well. And then that in the video as well, it was shown that a new drug available for the multi-drug resistance, such as your bedaquiline, linezolid, those can also be used. Then once again, this is the TB, the tubercle on the skin PPD test. Okay, this is how they inject it in this area, and then 72 hours, and they measure it and see how big that is. Okay, and remember, is that the whole bump thing they measure? It's not that if how far the redness is. Redness gets spread less or more, but we need to find this. Okay, and it is to detect the latent TB, not the active. So what they do is a small amount means 0.1 ml of the PPD, the tuberculin, is injected intradermally, just right under the skin. Okay, this area. And they observe it. So usually between 48 to 72 hours, they examine it, see the reaction. The induration means the raised and hard area, not just the redness. And then more than 5 millimeters is considered positive in immunocompromised patients. If they have HIV and other disease, that their immune system is weak, then even over 5 mm is considered positive. Now, over 10 mm is positive for individuals who have a moderate amount of risk associated, such as recent immigrants from high prevalence areas or healthcare workers. And for everybody else, it is more than 15 mm who does not have any known risk. That's what considered positive. Okay? Everybody is clear about those numbers, that what the criteria is. And an important factor, as I mentioned previously as well, false positive in people who had BCG vaccine, or they ever got exposed to, that, and they don't have active, but because they were exposed, or BCG vaccine, because of that, they develop antibodies. So they will come positive for this PPD test. Okay. Now, if we talk about the injections associated, first is that BCG. BCG is true. Why do we give it? It's a preventive vaccine against tuberculosis. Does it cover 100% risk? No, it doesn't. Lowers it, but most importantly is it reduces the severity mid-time. Somebody has that, most likely they're not going to have their lungs kind of much damage as compared to somebody doesn't. The factor we need to know is the patient who has this vaccine, they will come as positive, which is a false positive. They don't have active disease, but they have antibodies. So PPD, they will come positive all the time. Okay. Now, very important, because this is highly infectious and it's slow growing. Slow growing, as I mentioned previously, the slow growing are hard to treat. It takes longer, and that is the reason behind that usually the treatment goes over for months and months. If somebody asks you, for how long? So a successful treatment regimen, most likely somewhere from 6 to 12 months. Okay? It can even extend up to 2 years based on the severity and the risk associated. It can vary, but minimum 6 to 12 months. So please know that, okay? Minimum 6 to 12 months, which can extend up to 2 years. That is very important to know. Because patient might think, oh, I don't have symptoms anymore. Well, it doesn't matter. Doesn't matter. You're still not clear. Maybe you suppressed it, you suppressed it, you're not clear yet. So it's a long-term commitment, and a high level of compliance is required to treat this condition successfully. Because if they don't take the medication on consistent basis, what they're going to do, they're going to put themselves at a much higher risk where they were before starting it. Because now the bacteria is going to become even stronger. You made it weak, but it survived. And the person who survived the war, well, they are hard to manage. So they will become resistant, most likely, to the medication given. And that'll be extremely hard to treat. Please know the importance of compliance. You may see certain patients who are not compliant. They are monitored regular basis. The nurse, even if they're at their home, they're not compliant, the nurses go at their home, give them the dose, and then come back. So 8 doses they go and give them, make sure that the patient takes the dose. Because it could be a huge community challenge if they spread it out. That's a mess. Okay. And some of the drugs has high risk of toxicity, especially liver. So we look for yellow, 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 and we assess the liver functions. And I'm going to go over which drugs. Usually, they're your first line, such as your isoniazid, rifampin, and pyrazinamide. For these, you need to watch for hepatotoxicity, liver functions, yellow, 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 yellow. Okay, so this is important to know. Please note it down. Isoniazid, rifampin, and pyrazinamide requires liver monitoring. The reason, hepatotoxicity, and the signs and symptoms are yellow, yellow, yellow. Everybody clear? Any question?
Can you repeat it one more time?
Absolutely. INH is the first drug, isoniazid. Then RIF means rifampin. Okay, that's the other one. And the third one is PZA means pyrazinamide. Okay, isoniazid, rifampin, pyrazinamide. So they all require liver function monitoring. Then another thing, for drug isoniazid, or INH in short form, anytime your patient is on that medication, it's extremely important that you supplement with vitamin B6, which is pyridoxine, vitamin B6 pyridoxine. The reason behind that is the patient who takes isoniazid, the drug isoniazid reduces the absorption of vitamin B6. So they become deficient in vitamin B6. Now, what can it do? The deficiency of vitamin B6 can damage their nerves, can develop peripheral neuropathic pain. So, in order to prevent that, you supplement them with vitamin B6. And then there's another drug called ethambutol. Ethambutol. Ethambutol starts with E. That requires monitoring of eye, their vision, can negatively impact their vision. So you need to monitor their vision if they're taking ethambutol. And I'm going to go over this information again, but I just wanted to throw it once and then we'll repeat it. Okay. Now, one thing is always that susceptibility graph, which tells you that maybe these drugs, what are listed on your first line, how effective they're going to be and which will be more effective based on the data in your facility or in your area. So drugs can vary based on different facilities or that geographical region. Okay, but you should not wait for susceptibility results if you know the patient has that. It's better to start right away. And once you get the susceptibility results, maybe we can switch the medication at that point. Okay. Let me ask you this question. See if you know that. We talked about it. Okay, good job. Excellent. So in the morning, you want to collect it in the morning. You don't want to dilute the specimen or just wipe it off. And the sputum culture, it's taken 3 continuous days, 3 consecutive mornings, and the first thing in the morning. Okay. Now, as I mentioned earlier, compliance is extremely important. So you have to closely monitor the patient if they're compliant or not. They're taking it, if they're not refilling it on time, and you go and you see like bottles filled there, make sure they're taking it. If they're experiencing any adverse effect, and that's what is making them hesitant to take it, well, figure that out what it is, and maybe can switch the medication, but they have to take it consistently. So based on the type and the severity of the symptoms, you utilize the drug, as well as any underlying conditions they have. If any drug puts a patient at high risk of liver injury, well, if somebody does not have a healthy liver, we don't want to touch that. We need to go with other alternates. So we need to look into detail that which one is most appropriate for our patient. Now let's go over these drugs one by one. So if you remember RIPE therapy, first one is R. And under R, there are 3 drugs: rifabutin, rifampin, and rifapentin. R, 3 R's. Now what is important about it? We know this is an antibiotic. Number 1, these drugs start with R. Red starts with R, means it changes the color of their urine, saliva, skin, all excretions, sweat. You might see kind of orangish red kind of, on their clothes if it's light colored. The urine, everything will look colored. So just remember that. These R's will change the color. Alfred?
So this is like an expected, like normal thing,
Correct.
right? It's not
Yeah.
something that they should worry about. Okay, cool.
No. But it's important to educate. Okay, so that's one thing. Everybody understood? Anyone else with any question? Okay, no question. Let's move on. So what else is important about this drug? And that's equally important. Okay, equally important. We know here that it's gonna make all the excretions, all urine, feces, saliva, skin, sputum, sweat, everything is gonna be dark color. Educate them to drink at least 8 ounces of water when they take the dose. Okay, we can dilute it, correct? We can dilute it. And we suggest the same thing with another drug, which is not listed here, but will come later on. It's pyrazinamide. That also changes the color. That also changes the color of all these things which mentioned here. But I'll share that with you. It's a slight different. But for these three and pyrazinamide, all four, you educate your patient to drink enough water. Next important thing. One of the drug listed here in the middle, rifampin. Rifampin. And please make sure to know that if your patient is a female who's taking oral contraceptive, you need to educate your patient that this drug will make your oral contraceptive ineffective. Ineffective. They can get pregnant during that period. So what can we do? We educate them to use alternate methods of contraception. Everybody clear about that? Now, what happens is, like, now you have 3 drugs here, and you're going to see other drugs in the right therapy. And at one point, you find it hard to figure this out. Like, okay, which one was it? So please connect these dots. How I'm going to remember it's rifampin. Leave some sort of hint. Okay, it's a rifampin, not the whole class, not all of them. So we know oral contraceptive becomes ineffective, so we need to educate for alternate methods of contraception. It changes the color of everything goes out, whether it's urine, feces, saliva, sputum, whatever it is, sweat. And we educate them to drink more water. And rifampin here, and another drug is going to come later, which is pyrazinamide, which I told you will change the color of all these excretions similar to these 3 drugs. So rifampin and pyrazinamide, you can just maybe say PR, pyrazinamide, rifampin, or RP, whatever, however you want to memorize. They both put your patient at risk of hepatotoxicity, liver injury, okay? Hepatotoxicity, liver damage. So you look for that yellow, yellow, yellow. Any signs, the first thing you will see, the white part of the eyes become yellow. So if somebody does not have a healthy liver, they shouldn't be using these 2 drugs, rifampin and pyrazinamide. Okay. Now here's the second drug in the right therapy. We did R, this is I. I for isoniazide. In short, it's also called INH. INH. And this is also the first line. Now, what are the important things for us to know? Number one, there's a black box warning for hepatitis. So what does that mean? Number one, anybody whose liver is not healthy, we're not going to give it to them. And we want to make sure we educate the patient to monitor the signs and symptoms of hepatotoxicity, because it has a black box warning, which tells us there's enough reported cases of hepatitis. Okay, so contraindicated in patients with any liver disease. Other important thing, because this drug is metabolized in liver, it's metabolized in liver, you need to watch for patients who are called slow acetylators. It's, as I say, it's a genetic deficiency, and that can alter the outcome. Okay. Now, one more time. Do you remember I told you this drug, isoniazide, INH, will put your patient at risk of deficient in what? Anybody remember?
Was it B6?
Vitamin B6. What is another name of vitamin B6?
Biotin?
I'm sorry, what was that?
Biotin?
Biotin?
Pyridoxine. Pyridoxine, pyridoxine, vitamin B6. Make sure we give them pyridoxine, vitamin B6. And what was the reason?
Peripheral neuropathy.
Peripheral neuropathy. Good job. And with these patients, because it can cause liver injury, make sure you're monitoring their eyes, white part of the eye becoming yellow. Do you guys know what it's called? What it's called, Harjot?
Jaundice.
Jaundice is the name of the condition. I'm talking just specific white part of the eye getting turned yellow. It's an indicator.
The sclera, the white part?
Yes, sclera. It's called icteric sclera. ICTERIC. Sclera means the white part of the eye becomes yellow, which is an indicator of jaundice. Did everybody catch the name?
Can you repeat that, Professor?
Yeah. ICTERIC and sclera, SCLERA. That simply means the white part of the eye becomes yellow. Okay, everybody got it? Everybody clear what is important about this drug? Okay, any
Yes.
question? Okay, let's move on. Now the next is P, R-I-P-E. We got R and I, now it's a P. P is pyrazinamide. Pyrazinamide. Now if you remember, this drug also changes the color of secretions, but they are little less dark as compared to the R's. The first one we studied. So this becomes more yellowish orange. And same education, drink at least 8 ounces of water. Dilute it. So this is also contraindicated with patient who has liver disease. And if somebody has an acute form of gout, which it can make it more worse. And that is another reason to educate the patient to drink plenty of water, to dilute it so that there are less chances of crystallization and making the gout more severe. Okay, because gout is caused by a high level of urea, hyperuricemia, and then uric acid levels high, and this drug can raise that as well. Okay. Here is the last one in that RIPE regimen, ethambutol. Now, once again, if you remember, ethambutol starts with E, I starts with E. So with this drug, it's extremely important to monitor patients' vision. So that should be a part of your nursing care plan. If your patient is taking ethambutol, to check their eyes frequently. The condition called, which can develop, that is optic neuritis, which means inflammation of the optic nerve. Inflammation of the optic nerve called optic neuritis that can develop in patients who are on this medication. So we are going to monitor their vision frequently. Okay, everybody clear? Understood? Any question? Okay. Hey, Vishal, did you check in or no?
Yes, Professor, I joined about 15 minutes ago. I was doing Complio stuff at my primary care physician, and there was no internet or access there. So,
Okay, but did you scan the
no,
QR
I didn't
code?
check in. No, I had no connection over there.
Okay, so anytime any of you, if you're not able to scan it, please let me know.
Yeah,
What time did you come in?
I came about 20 minutes ago.
20 minutes ago. Okay. So that is let's say
11:30.
11:30?
Yeah.
I'll check you in at
Thank you.
11:30, okay? Always, whenever I mean, it happens, either technical issues or anything, let me know right away, because what happens is within a certain time frame, I can fix it real quick. But if we don't, then it has to go through registrar, and there's a whole lot of process. You have to fill these form, that form, and that can take longer. It could become a little complex. Okay. Alrighty. So ethambutol, we all clear. We're gonna monitor patients' vision, 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 and vision. Okay. Now there's some other drugs, okay, such as your streptomycin. So now that is the second line. If the patient has multi-drug resistant tuberculosis, then they're not probably going to respond to the first line. So we go with the second line. Or if they cannot take any of those, then you can do that. So streptomycin, it is an aminoglycoside. And as soon as you read the aminoglycoside, make sure the aminoglycoside comes with a lot of adverse effects. Okay. Do you guys remember yesterday we were studying one of the aminoglycoside? I guess it was gentamicin, right? Do you guys remember what was the adverse effect?
Was
Do you
it
guys remember? No.
nephrotoxicity and ototoxicity?
Yeah, remember, no, aminoglycoside cause no means nephrotoxicity and ototoxicity. So nephro means kidney damage, auto means hearing loss. Okay, and another thing I want to point out here, it's good to know. You guys all know, right, that the middle ear is also responsible for the balance, right? Is now correct? So in this case, you may see some of those issues as well because, if it's impacting that area, your patient may show those sort of symptoms as well. Okay. All right. Mhm. Mhm. Do you guys want to take a break? Yeah. Okay. So it's 11:57, and you're gonna take you can take 15 minutes. Okay. We have the time today, so I'll see you in 15 minutes. Okay, welcome back, everyone. About time. Okay, let's move on. This I want to just go over and let you know here. The patient taking TB, the patient who has TB will be taking INH, which is isoniazid, part of antituberculosis therapy, reviewing chart, nurse find documentation. Patient is a slow acetylator. So what that means? That simply means that when INH is taken by slow acetylator, the isoniazid, it accumulates because there are not enough liver enzymes they have to break down isoniazid to excrete it from the body. So in that scenario, the dosage of isoniazid may need to be lower down to prevent any potential toxicity. So A is the correct choice in this. Okay. Has everybody understood that? Or anybody still or missed any part of it? Okay. Now this is just a repetition, okay? We studied this, we discussed about this, but just kind of revision again. Adverse effect part. Isoniazid. We all know isoniazid can cause peripheral neuropathy, hepatotoxicity. So vitamin B6 is important here. Ethambutol with E requires eye exams, right? Monitoring the vision, patient vision can cause neuritis, blindness. So we need to monitor that. And the one starting with R, rifampin, rifabutin, rifapentin, they changes the color of secretions, right? Orange to red. Now, adding in here, rifampin and parazinamide, both can put your patient at risk of hepatotoxicity. So monitor liver. Somebody asks you if they're taking any of these medication, what are you going to monitor? Well, the lab values for what? Liver. Okay. And the patient who is taking isoniazid, we know that hepatotoxicity is a risk. So we're going to monitor patient's eyes, the white portion of the eye turning yellow. What was the term again?
Sclera.
Yeah, good job. Okay. And then neuritis was the inflammation of the optic nerve, which can damage their vision. Okay. And for rifampin, what else do you remember? There was another criteria what we need to educate the patient about.
Oral contraceptives. If the patient is female, then she'll need to either decide to take another form of contraceptives.
Perfect, perfect. Good job. Yes, so it makes the oral contraceptive ineffective. So we need to educate the female patient of reproductive age that should use alternate methods of contraception while you're taking this medication. And because it makes the secretions dark, we also need to educate the patient to drink more fluids to dilute it. Okay. Any questions so far, guys? Anything? And I just want to remind you again, these things are going to mix up, so please organize them. Because probably by tomorrow or in a couple of days, you might find it hard to like, okay, which one changes the color? Which one does red? Which one does like orange? And which one I need to educate about for vitamin B6 or these oral contraceptive. So please align them correctly. Okay, nursing implication, once again, how to keep your patient safe and how to manage their condition. Well, know the patient, assess thoroughly, and then the drugs which can impact their liver will first perform liver function, see if it's even safe to give it or not. But even if it was, and they are on this medication, monitor their liver function so that you can catch it early. Okay, so for your isoniazid, rifampin, as well as pyrazinamide, they can cause hepatotoxicity, so you should be monitoring liver functions for these three drugs. Just remember RIP, R-I-P, RIP. RIP means rifampin, I means isoniazid, P for pyrazinamide. RIP needs liver functions. Okay. Okay. Now, once again, that repetition we talked in the beginning itself, that this condition requires high level of compliance when they're taking these medications. They can't skip a dose. And they can't stop taking even though they feel better, even there's no symptom. They have to complete the whole course, which can last somewhere from 6 to 12 months and can extend in some cases to 2 years as well. Usual 6 to 12 months. Same time every day. It's important to have consistent amount of drug in the body all the time. Another important aspect. Now your patient might start taking medication. They don't have symptoms anymore or not that severe. Patient may think, oh, I'm okay. Well, they need to understand, even though they start feeling better, but they can still transmit it to other healthy people who they live with, their family members, people they work with. So make sure they understand that risk in the beginning itself, that they're still contagious. So cover your cough or secretions and practice hand hygiene. This is important. And we talked about the oral contraceptive part, that rifampin makes oral contraceptive ineffective, so we need alternate methods of contraception. Also, educate your patient, do not drink alcohol with this medication. Okay. As we talked previously as well, guys, the drugs starting with R, rifampin, rifabutin, rifapentin, they changes the color of secretions, whether it is urine, stool, saliva, sputum, sweat, everything going on becomes a bit dark. Reddish orange or orangish reddish, whatever you want to call it, but it's more darker. And if you can read there, it says even contact lenses may be stained. So if they wear contact lens, it will be ideal to educate them that maybe they might want to use the glasses rather than the contact lenses during that period, because they may get stained and they won't be able to see it clearly. Okay. The second, the middle paragraph, once again, we did go over that earlier. It's about isoniazide. The patient becomes deficient in vitamin B6 pyridoxine, which can cause peripheral neuropathy. So in order to prevent that, we need to supplement with pyridoxine, which is vitamin B6. Okay. Now the bottom paragraph is pretty common, general, that not only for this medication, it's generally, criteria for all. If any other medication is causing some sort of GI issues, then it can be taken with food. I'll be monitoring therapeutic effect, we'll be monitoring adverse effect. And in order to monitor the adverse effect, we should know first that what can happen. Like as we talked about, isoniazid can decrease the absorption of vitamin B6, then the peripheral neuropathy, what are the signs and symptoms, numbness, tingling, all that. We should be aware about that. What are we trying to monitor here? So if your patient reports that they are experiencing numbness and tingling in the extremities, so what does it tell you? Doesn't tell anything?
That they have an allergy or we should decrease the dose.
What we just talked about. Isoniazid, they're saying I'm feeling numbness, tingling.
Low vitamin B6.
Yeah, vitamin B6 deficiency. That's called peripheral neuropathy. It's not reaction. It's not adverse reaction. Okay. Now, monitor the therapeutic effect. Start from the beginning. Pick up where you started from. What were the signs and symptoms before the patient started this medication? And then ask the patient or assess the same signs and symptoms. Compare them both. Are they same, less, more? That will give you a clear picture that if patient is still at the same platform or they're moving forward, less or more, the symptoms are decreasing. Okay. Okay, let's see this question. Excuse me. Okay, good job. So here we need to look into that angle of what is wrong here. So if you're saying that because my oral contraceptive will not work while I'm taking a FEMPEN, I'll use another form of about control. That's what we exactly talked about earlier. That will make oral contraceptive ineffective, and we need to educate the patient to use alternate forms of contraception. So that is completely correct. I'll take the medication for 1 week and then stop. What did we say? For how long minimum?
6 to 12 months.
6 to 12 months minimum, which can extend up to 2 years. So that is something we need to re-educate them about. Yeah, I can make sensitive to sun, that is right. And then the change in color urine, that is also aligned with what we discussed earlier. Okay. Do. Okay, let's see this. Excuse me. Okay, great work. Very good. Yes, C is the correct answer. We know that the patient probably deficient in pyridoxine, vitamin B6. So in order to prevent that, we need to give them pyridoxine vitamin B6. It is not a tuberculosis drug. It's not. We are trying to prevent a secondary issue which can arise because of the drug they will be taking. Okay. Okay, once again, well done. D is the correct answer. We know it can change the color of secretion, but it is non-harmful. It's known, expected. Only thing we should educate them about that, okay, drink more water to dilute it. And if they're wearing contact lenses, then maybe they should look for alternate during that period. Maybe they want to wear the glasses. Okay. All right. Once again, good job. The answer is B. Ethan butyl. Ethan butyl starts with E. I starts with E. So E causes another problem with an E. So we need to monitor their vision. Okay. Okay, nice. Perfect, perfect. Yeah, D is the correct one. Okay, one more time. All right, perfect. B is the correct one. Vitamin B6, which is pyridoxine, and we give it to prevent peripheral neuropathy. Okay. All right. I guess that, okay, let's do actually an NGN, okay, new generation. Let's read together. 77-year-old male client in the hospital with 3 days of progressive weakness, fatigue, chill. Okay, patient sick. All right. The client present with confusion oriented to name only. So daughter at bedside, provide the nurse information. He denies constipation, lightheadedness, palpitation, burning, this. Client has medical history of hypertension, atrial flutter, angina, BPH, depression. The provider's note indicate that infection suspected. The patients weighed 189. They gave them ciprofloxacin and antibiotic IV twice daily for 7 days. Okay. Nurse assesses the client, assesses the morning lab, reviews the medication administration record. Clients at home, newly prescribed medication. Okay, vital signs 99.8. Okay. Heart rate 88. Respiration 18, blood pressure a little down, oxygen, not bad, weight, okay, all right. Now let's look on the lab. BUN. The BUN is 53, the normal is between 6 to 20. Is it normal? So that's one problem. Creatinine, 2.46, normal 0.67 to 1.7. That's also high, correct? That's a problem. We got two problems. Now, BUN creatinine, what are they associated with? Which organ?
The kidneys?
Kidneys. So that gives us an indication, something going on. Creatinine clearance, 30.5. It's less, supposed to be 107 to 139. Once again, kidneys. Potassium, 5, fine. Sodium, that's good. Hemoglobin is low, right? 10.9. Hematocrit, low. So we are looking here, BUN creatinine clearance are high, and hemoglobin and hematocrit, they are low, right? So something to do, something relevant to kidneys, and then also that anemic part, right? So now let's look other angles. WBC, so should be between 5 to 10,000. It's 1,800. High WBC, what does tell you? Somebody has a high
A
WBC.
possible
What does it
infection.
tell? Infection. Cholesterol 275. Yes, but cholesterol can cause infection. Okay. Now, urine lysis, color, yellow, appearance, cloudy. Is the urine supposed to be clear or cloudy? Clear, right? So cloudy tells you what? If the urine is cloudy.
There's probably
Is
some sort of infection.
Infection. Now, infection where? Where does the urine come from?
Kidney.
UTI.
So kidney, we see the values, right? And then it comes through the urinary tract. So what are those infections called in that area?
UTIs.
UTI. So that should give you kind of an indication, hey, maybe this patient is having UTI, which is causing the kidney functions to alter as well. Okay. Let's look into other things. Glucose normal, ketone okay, specific gravity 1.0, that's okay. RBCs, look here, RBCs more than 2, supposed to be under 2. Once again, signs of infection. pH okay, protein, nitrate, WBC in urine as well over 50, supposed to be between urine 0 to 4. Once again, confirming what? Infection. Are we all on the same page? Yeah. The patient is taking all the medication. See, the tamsulosin tells you the patient has BPH, benign prostatic hyperplasia. So BPH patients has swollen prostate gland. And the BPH patients are always at a high risk of urinary retention, causing UTIs.
Right up here. Oops.
Okay. So these patients are always at high risk. Let's look into now. They are saying we need to identify the condition, action to take, and parameters to monitor. Now, potential condition out of these, all the values indicating what?
UTI.
UTI, correct? Nothing else. UTI, we got that. Now, signs and symptoms. How did we come up to this conclusion? Disorientation and confusion. Did the patient has it? Yes. Alan, yes. Severe UTIs can cause, especially in older patient, disorientation, confusion. Can cause that. Okay. Now, oxygen saturation, 94%. That's normal. Cholesterol can't cause that. Negative nitrate on urine, no, that's nothing to do. Elevated WBC. So the two things here, signs and symptoms, those are your disorientation, confusion, and the second one is elevated WBC. These are the two signs and symptoms which indicates patient probably has urinary tract infection. Now, what should we monitor? Vital signs? Should we monitor vital signs? Always. Always monitor vital signs. Okay. Confusion. See here, disorientation, confusion. So we should monitor that as well. Specific gravity, sodium, potassium, they were all normal. We don't need to look into that. So vital signs and confusion, these are two parameters which needs monitoring. And here you go. Everybody agrees? Yes? Anybody have a different opinion? Okay. Any question, guys?
Wait, wouldn't the specific gravity matter as well? Because from what I know, the specific gravity helps test the kidney function. Would that be necessary to know in like a UTI?
Okay. We are coming to that conclusion based on the values given to us. Now, if you take a look, specific gravity, is it normal or abnormal? That's
It's
within the
normal.
limits. It's normal. So if you talk about general, like, is that important or not? Like, all the values are important, but we are deciding based on these numbers. And in these numbers, gravity does not require monitoring there at that moment. In this case, from the given values and signs and symptoms, so we need to monitor vital signs and confusion. But is it an important factor? Yes. Once again, for this case, they're asking what you should be watching. Make sense?
Yes, but also I think I was leaning more towards like, is there ever a case in where someone has a UTI and their specific gravity is out of the range?
Yes.
Okay. So we would also have to consider that too, right? If this
Correct.
was like
So
a question for us.
yeah, if they give you that, for example, here in this particular case, the specific gravity was normal, right?